Thank you, everyone, for joining us. Sorry for we're starting a couple minutes late. So we had to improvise a lot to fit in this room. I did not pick this room. We're doing the best we can with the space we have, but it's a fact that it's going to be a little bit crowded. We're going to remove the chairs for the hands-on section, but just bear with us. So welcome. I'm Felipe Teran. I'm an emergency physician. I work at University of Pennsylvania. I am here with a team of people representing the Academy of Emergency Ultrasound, led by Megan Leo, who is right in the back, who will be one of the faculty, and also she's taking part of the course. And then Aydin, who is the lead, the president of the Critical Care Medicine Interest Group. So this was a joint effort from the critical care group and the ultrasound community that reflects what we think the vision that we have of point-of-care ultrasound and specifically resuscitative TE. So with no further ado, we have Rachel Liu, who will be helping us with the TTE, advanced TTE stations. Nova, my associate director of associate director of ultrasound at University of Pennsylvania. Rachel is at Yale, as you all know. Mark Andreae is the senior resident at Mount Sinai in New York City, along with Clark Owyang. Both of them are critical care bound, and they were very involved in the development of the TE program that we started at Mount Sinai. Together with Bret Nelson, who needs no introduction, also will be doing hands-on teaching on both TTE and TEE. Ross Kessler, currently at University of Michigan, who is also doing a lot of TE there, will be helping us with TE hands-on as well. Kenton Anderson, another good friend, who is ultrasound director of research at Stanford, also with a lot of experience in the lead author of one of the most important papers in resuscitative TE in animal that we'll be talking about briefly here. Finally, hiding in the back, I have Ani, who, as you know, is also a critical care, critical care physician who works at Yale. Here's some of the details. I want to thank HardWorks from Metaphor for powering this simulator, along with this workshop, along with Philips, who's providing us the 4 Spark machines. HardWorks is providing us all the simulators that we'll use for the TEE instruction. And finally, the Resuscitated TE project is a independent group that has come together, multidisciplinary effort to try to promote, expand, and advance the field of resuscitative TE. We'll be using a lot of the resources and graphics and cases that have been put together by the group behind the Resuscitative TE project. So we have, this is a group of faculty. We have a large group of participants, which we're very happy about, but it reflects the amount and overwhelming interest that there exists right now, both in emergency medicine and critical care for resuscitative TE. I want you to pay attention, look for your name, because these are the groups in which you will be starting when we start the hands-on. So if you missed this in the email that I sent, please make sure that you find your name and know which group you are so that you know where to go. Those are the other 5 groups. If after this slide there's someone who has not seen his or her name, raise your hand. You both? Okay. At the end of the this introduction, just come to me to get you assigned stations. Okay. So the goals of this workshop on the TEE side are primarily to understand the principles of TE operation, to understand the indications and the applications of each of these 4 views of the protocol, and then get comfortable with image acquisition, identifying the anatomy in those 4 views, correlating the anatomy with TTE views, and finally identify some basic pathology, which we'll do with cases that we have from real patients. For the advanced TTE, the story behind this section is that when we came together with the critical care folks, they asked us to include some advanced TTE topics because they felt that within the critical care community, there was a need for to expand sort of the repertoire in some of these topics. I know that some of you here are advanced users of point-of-care ultrasound. So for many of you, this will be stuff that you already know. You're free to step out if you don't want to do it at all. If you want to take advantage of the hands-on opportunity that we'll have with the instructors in the models, you're welcome to stay, obviously. But we're aware that there'll be a lot of variability in terms of your background of experience. And we ask you all to just be understanding and sort of go along with it. Program, we're going to go until 1:30, actually more like 1:40 with the introduction, and then we're going to break into two groups. I'm looking at probably going to end up, we're going to end around 5:05, 5:10. So we'll have two blocks of 105 minutes for the hands-on. That will serve for TTE, which will be first 105 minutes, and then TEE. And 4 groups will start in one side, and the other 4 groups will start in the other side. So we have all the stations with TEE on this side of the room, and the TTE topics are going to be on this side of the room, on the left side. For the hands-on sessions, the groups 1 to 4 will start on the TEE on this side. So if you remember your name, the group that you are, just when we break, you'll go directly to that station. At 3:15, we'll switch between groups. We have 25 minutes per station, so we'll be announcing at every 25 minutes the time mark for the groups to switch. The idea, and this is obviously not a ton of time, so we need to be as efficient as we can with the goals that we'll be sort of setting forth for each one of those stations. And you have these materials. Hopefully, most of you had the chance to look at them. These are the faculty that will be leading each one of those stations. All faculty have this orange lanyards so you can recognize them. Not that you need to recognize Bret Nelson or Noah or any of them, but because I'm sure you know them. So for the hands-on station specifically, these are the goals. We're going to try to stick to those goals, again, for each one of those stations. For the station covering anatomy and imaging planes, we're going to try to spend most of the time trying to understand, sort of wrap up our minds around the orientation of the anatomy from the perspective of the TEE probe. And then once we do that, try to develop a mental representation of the structures, because as I'll point out later, if you're able to do that, you don't really need to memorize the omniplane angles in which you find each of the views. If you actually understand the anatomy, you can find whatever view you want, understanding the planes. For stations B and C, both of those stations and TEE are going to be covering, are going to be sort of redundant stations covering sort of the meat of T, which will be the resuscitative TE protocol. There's 4 views. We're going to try to really make the point that you establish a systematic approach to scanning, just like you do with TE. But with TE is even more important because, as you will see when you start doing real cases, there's a lot of difference between a simulator and real patients. There's a lot of anatomic variation, and for that, it will be critical for you to have a systematic approach to transition between views and to develop each one of the views. For clinical integration, we're going to be running some real cases from emergency medicine and some from critical care to sort of integrate this sort of clinically relevant pathologies with the learning that we'll go through in TE. For the advanced TE, the topics that we've selected, which were sort of requested by the critical care people, are these. Again, we're just going to it's going to be an introduction to those concepts, but ideally we'll have the opportunity to practice each one of those things in the models. These are the goals for each one of those. Again, you have this information in the PDF that I send you. Of course, if there's other stuff that you want to cover, feel free to take advantage of this opportunity to ask questions to the faculty and take whatever you really need. This is our room, and as I said, we're going to be using HardWorks TE simulators for the stations. So now that we've taken care of that business, I'm just going to give a quick review on the fundamentals of resuscitative TE. I want to make sure that we all start with the same sort of base of knowledge of information, and I'm aware that many of you have some experience, but we want to sort of set the base for everyone. So this is a picture of our resuscitation bay. Nova Panebianco is leading a resuscitation of a patient that is being put on ECMO. We're using TE to guide the resuscitation, to assess qualitative compressions, to identify reversible pathology, and among other things, to assist the cannulation in real time that our cardiothoracic surgeons are doing to identify those wires, as I'm going to show you in a couple of cases coming forth. I have a couple of disclosures to make that relevant for this presentation. And I wanted to make sure that you're all aware that the only reason why I'm here talking about resuscitative TE is because I owe a tremendous amount of learning and time spent by these people teaching me and giving me opportunities and helping me develop what we've been building originally first at Mount Sinai and now at University of Pennsylvania. So some of these individuals are here, and I just wanted to make sure that they get the credit that they deserve for pioneering this new application of ultrasound. Some of the graphics, actually all of the graphics that you'll see in many of the posters that you'll see around the room are generously shared, donated to us in terms of the opportunity to use this graphics by Hardworks. So these are the three things I'm going to tell you right now. What is resuscitative TE? What is this concept of resuscitative TE? Why it can be why it can improve care, and then how we can start a program. I'm not really going to exactly describe in detail all you need to start a program. We don't have the time for that, but I'm going to give you the main elements that are important. So what is resuscitative TE? Resuscitative TE is the use of 4 views that we've selected, and it could be 4, could be 6, it could be 7, but conceptually is a small number of views that we've identified as high-yield views to answer most of the questions that we care about in the setting of assessing someone hemodynamically unstable or in cardiac arrest. That is to distinguish from comprehensive consultative TE, which involves 28 views. If you're a cardiologist or cardiac anesthesiologist and you spend time with any of them, you know that in the operating room, they will go through that very comprehensive set of views, which is meant to provide diagnostic and very accurate information. And as you all know, that is not what we need at the bedside to guide resuscitation in critically ill patients. So that is the concept of resuscitative TE. We don't own resuscitative TE in emergency medicine. Intensive care physician, an emergency physician, a surgeon working in trauma, an anesthesiologist, anyone can use transesophageal echo with a focus protocol, with a focus approach, and that is what we're calling resuscitative TE, and that's what we're embracing this as a modality that should really belong to all specialties that have any involvement with critically ill patients. So these are the views that we're going to be working on and focusing today. Mid-esophageal 4-chamber, mid-esophageal long axis view, transgastric mid short axis view, and then mid-esophageal bicaval view. As you know, and you're probably familiar with, 3 of these views, the first 3 views have equivalent in transthoracic views, right? 4-chamber views, our apical 4-chamber. The mid-esophageal long axis view is essentially our parasternal long axis. The mid-esophageal, the short axis, transgastric short axis, sorry, is equivalent to our parasternal short axis. And finally, bicaval is the one view that really doesn't have an equivalent in transthoracic. So spend some time trying to understand the anatomy of this one view. So I tell you exactly what we're defining as resuscitative TE. Now let's talk about why TE can improve care in your critically ill patients. So the main argument is here. Echo is the standard of care for the assessment of patients with hemodynamic instability and shock in the emergency department, in the operating room, in the floor, in the ward, whatever it is. That is the standard of care, and we're not meeting the standard if we don't do that. But sometimes we can't really commit, we can't really meet that standard of care. not because we don't want, but because the tool that we have, transthoracic, just doesn't allow us. Either because the patient has COPD and the emphysema doesn't allow us to get good views, or because of presence of mechanical ventilation, or because it's an obese patient. In those situations, we simply need a better tool to meet that standard of care, and that tool is TTE. Because of this unique location in the esophagus, TTE is not affected by all those common limitations of transthoracic, such as obesity, lung disease, and again, mechanical ventilation. So conceptually, TTE, and this is important because when you start programs at your institutions, this is what I think you need to tell those that you need to convince. TTE is simply a tool that is the right tool for a certain group of patients, and you need to have the right tool for the right job. Acknowledging that and acknowledging the body of evidence that already exists, the ASAP published last year consensus statement in which Ross Kessler was involved as one of the authors, and they're basically recommending the use of resuscitative TTE specifically for cardiac arrest by emergency physicians. So what are we doing right now? I told you that it's critical in shock when we can't adequately assess patients with transthoracic, but specifically in cardiac arrest, which is, I would say, the main indication right now, how can it improve the care of our patients? Number one, it can help us identify reversible pathology, just like TTE. It can help us assess the efficacy of our interventions. It can help us assess CPR quality. This is something that we can't really do with transthoracic. And finally, it allows us to guide procedures during the resuscitation. So just to give you some examples, this is a case of a clot in transit, seen a mid-esophageal 4-chamber view. Again, we're focusing the view here on the right atrium and RV here. You see our dilated RV and RA with that thrombus. Aortic dissection, we have really, really clear views of the aorta. So either short axis or long axis view of the descending aorta can identify this dissection flap really nicely and easily, and we've done this in the early phases of our cardiac arrest, for instance. Fine ventricular fibrillation, a very well-described entity that we need to treat with electricity. And yet many of these patients, as we know from the literature, are unrecognized. And we think that what we're seeing is PA, but yet when we take a closer look, when we get a better definition of that ventricle, what we see is this, a myocardium that is fibrillating. And most of us who've been doing TTE systematically in cardiac arrest have had several of these cases where we will defibrillate the patient and the patient will get ROSC in many of those cases. So fine ventricular fibrillation that we could not otherwise identify based on what the electrocardiographic tracing is showing. Mechanical reasons. We've had cases like this one of a displaced pacemaker lead that basically went to poke the intraventricular septum and was found to most likely be the leading cause of that refractory ventricular fibrillation that the patient had. You won't fix this problem with chest compressions. We need to improve that mechanical problem. Another case of obstructive shock, a patient that came in arrest. This is the first image that I got. So this giant tennis ball, right, in the right atrium is an occlusive thrombus with a completely empty RV. So this is pathophysiology of obstructive shock. You can't treat this with ACLS, with compressions, with epinephrine. We need to release that. And so the treatment of that, and just as an additional view, this is the bicaval view, the SVC. There was a pacemaker lead extending, the thrombus was extending, and we could see it clearly sort of surrounding that lead. We can also assess the interventions that we start in those patients, such as that same patient. This is TPA given for this patient for the same tennis ball that I just showed you. We were able to see in real time that clot basically being dissolved and the pressures, the PA pressures improving, that RV gaining form and the output improving. So you can see the role of your interventions, again, in real time, something that you couldn't really see without TE. This is the same hard post TPA. This eventually got ROSC. Optimization of area of maximal compression. This is something that Kenton Anderson, again, has led the work. We're doing a clinical study to further prove this in humans, but he did the first animal study where basically we confirmed what we knew from several radiology studies that have been telling us that this area of maximal compression, the area where we compress when we press with our hands or mechanical device, is really not the left ventricle, unfortunately, in over 40% of the cases. In over 40% of the cases, what's happening is that we're compressing the LVOT or the ascending aorta. This is a metaesophageal long axis view. So when this happens, it doesn't matter if you believe or not in the cardiac pump theory or the thoracic pump theory, but there's no cardiac output coming out of that aorta if you're occluding the aorta or the LVOT with your compressions. So in those cases, we've seen hemodynamic parameters, end-tidal CO2, diastolic blood pressure as a surrogate of coronary perfusion pressure, and we've seen those parameters improve when we relocalize, when we move the hands or the mechanical compression device to better compress the left ventricle instead of that structures at the base of the heart. And when that happens, we've seen those hemodynamics parameters go up, and we're working on validating that, again, with better prospective evidence. So that's the original study. I invite you to check this study. I believe is game-changing, and it's one of the most important, I think, applications of transesophageal echo in cardiac arrest, and I believe that it potentially could significantly improve outcomes of patients with non-shockable rhythms. There's another example that we had just the other day, compressions occluding the LVOT at arrival, in this case with mechanical CPR. That is the same patient seen on transgastric short. Again, you don't need to understand much CPR physiology to understand that this left ventricle here, that's the RV, the left ventricle here is not really coming together. So whatever you're doing, you can press as hard and as fast as you want. That is probably not producing any meaningful cardiac output for you. So another example of more inadequate CPR, another case completely obstructing the ascending aorta. That's the same case after repositioning that area of maximal compression. Finally, we can guide procedures. We guide the placement of intravenous pacers instead of just poking and waiting for the electrical activity on the monitor like Roberts and Hedges will tell you to do. We actually visualize the wire advancing to the right place, the lead to the right place. And another emerging and really important application that has been game changer for us, as well as many other institutions, University of Utah, Jimmy Fair and Mike Mallin have led the work and have published a case series on this, is the assistance in real time of cannulation for ECMO in patients being put on ECPR. So this is an example of one of our cases recently. Patient is being cannulated, the fem artery and fem vein to be put on ECMO. That is the arterial wire, and that's a venous wire. And that is how we see the arterial wire on the descending aorta. That's in the long axis. That's the artifact. And that is an actual clip of the arterial guide wire into the descending aorta. You can actually see nicely the coil there. That's the end. So this is basically gold standard for us to demonstrate that we are actually in the artery when we think that we are in the artery, to avoid those cases where we put the patient on pump, we turn it on, and we realize the patient is it's actually in VV ECMO, which, as you know, doesn't really work in cardiac arrest. So this, again, allows you to not only look at the wire in the descending aorta, but also assess accurately the placement, the position of your venous wire, of your venous cannula in the descending, in the IVC going into the right atrium, as shown right here. That is the, actually that is the guide wire, and now you see the cannula actually being advanced. This has really changed our game. For instance, for patients with VV ECMO, with Avalon cannulas, for instance, for those practicing critical care, it really allows you to very accurately identify the position of that cannula to optimize your flows. And that is the patient successfully put in VA ECMO. That's tracing color. This is artifact. This is just to show continuous flow of the patient successfully put on pump. And finally, how to start a program. Many of you here are already either interested or decided and working to start programs. Again, we don't have the time to comprehensively cover that, but our team has put together a set of 2 lectures, part 1 and part 2, that are available on the Resuscitative TTE project website that covers sort of the nuts and bolts of setting out a program, with covering all the implementation from, you know, the key articles, all the evidence that you need to have on the table when you talk to your decision makers in your hospital, how to define the program scope. We shared the actual protocol that we use, as well as many other protocols from other institutions that are available on the website, how to get a probe, how to go about cleaning it. Should you clean it in your department, or should you send it for central? In the second part, we cover what are the main training modalities, the very controversial issue of credentialing, which many people are having trouble with, and privileges, and finally, what are some of the learning resources. But the 4 things that you do need, in my mind, obviously you need a probe. And the message that I want to give you is that you need a probe that ideally works with the machines that you have already. You don't want to have to switch to a new vendor system, because at this point, most companies, including Philips, who's here and has one for demo, most companies in point-of-care ultrasound are offering TE probes. Second, you need to come up with a training solution that be ideally a simulator, like the Hard Rock simulator that you'll use today, but you should complement that with some live training in either the OR or in the cardiac lab with cardiology. Whatever you can get. In our experience, it will help you significantly to actually spend time doing TEs in real patients. One point that I wanted to share with you is that what we've learned is that the simulators are expensive, and many institutions already have them. In most cases, by anesthesia owns them. And what we found in New York is that they were really underutilized in some of those departments. So us, emergency medicine, in comparison to anesthesia, there's a relatively much lower frequency of cases that we will be doing in the emergency department or in the ICU. So for us, even more than for cardiac anesthesia, I think simulation in TE is going to really play a critical role, both for initial training for competency development and also for maintenance of your competency. Number 3, you want to make friends. You want to find someone in your institution that believes that TE can help your patients. What we call a believer. That is Mark Stone from Mount Sinai, who was an incredible supporter of our program there, who not only opened the doors of his OR to train our people, but also then participated from courses and training that we did together. So you want to identify that person. And finally, this is also a lesson that I've learned in the experience of setting up 2 programs at this point, is that you need to expect resistance. Just like Laennec with the first stethoscope, to the Liebmann, to any of these handheld devices, you all remember each one of these pieces has at some point been considered either too expensive, too cumbersome, additional skills are required to operate them, and all those things have been raised as arguments against their use. So you will see the same thing for TE, and it's important that you anticipate that and that you acknowledge that there will be early adopters and there will be late adopters, as everything. And finally, I want to make sure that you have this website. We have a ton of resources that are free on that website, including protocols, free open source lectures, some write-ups, blogs, and again, a lot of helpful information if you're setting up a program. One of the things I want to highlight is we've started a collaborative. We're basically bringing together all the groups that in the country and internationally are starting to do resuscitative TE in emergency medicine or critical care, and we're coming together to do 3 things, mostly regional collaboration. So we've done 2 simulation sessions in New York with Mount Sinai and with NYU to share the simulators that we have. And hopefully this month we'll be starting with the second virtual rounds, basically reviews to share with these other institutions a good opportunity to discuss some of the challenges that that someone might be having that might benefit from the experience from other institutions. And finally, Kenton, Ross, and I in the SAEM group are working on some multi-center research at this point, which we very much need in order to advance knowledge in this area and actually come up with the evidence that we need to change practice. Another sort of interesting thing that we did was the 3D printed project, which you will actually be able to use today. We developed with Jefferson Design Lab this 3D printed models that are available open source on the website that you can download and send to your favorite 3D printer to print, and you can have next week the same pieces that were developed following the cuts of the TTE views that we'll be learning today. So that we learned that it was a really useful thing to make people help people understand the different planes in TTE, which for the most part are difficult to understand. As William Gibson said, the future is here. It's just not evenly distributed yet. And with that, I thank you for your attention. And we can break actually in 2 minutes. What's that? Yeah, they have two. I want to show them one slide. Actually, 2 slides. It's here. So there's one thing that is important in terms of the knobology, and you'll have chance to see these videos in the real simulator. We'll be thinking about the anatomy today from the perspective of the probe. The probe has a big wheel and a small wheel. You'll see the real probe here that does anti-flexion and retroflexion. Again, you'll be able to play with one. But I want everyone to use the same language today, to communicate using the same terms. So we're going to be doing either advancement or withdrawal of the probe. So advance the probe and withdraw the probe. We're going to be doing, and that is reflected by that. So that is what advancing and withdrawing will look like. That is what that mechanical movement is doing. The rotation of the probe will be basically the mechanical rotation of the probe with our hand, left or right, and that will displace the beam left or right. So that is rotation of the probe. And finally, anti-flexion and retroflexion, which it is simply again flexing the actual probe forward or backwards. That will be particularly helpful when we do the transgastric views. Rotation of the omniplane, we have the mechanical movements that I just mentioned, and then the rotation of the omniplane is the digital movement of the crystals that allows us to rotate from the perspective of the probe clockwise from 0 to 180 degrees the beam in order to develop both horizontal planes and vertical planes that will give us all the views. So when we're in the horizontal plane, patient's left, it will be on the left side of the screen, and patient's right will be on the right side of the on the patient's right will be on the left side of the screen. But again, I want you to think about this from the perspective of the probe, because that will make it significantly easier. This is what you'll see on the screen in the horizontal planes. This is patient's left, that is patient's right. When we go to vertical planes, so 90 degrees, then the superior and inferior anterior remains to be the apex. And this is important, for instance, when we do the bicaval view. This is what explains the fact that the SVC is on the right side of the screen because it's superior. So just think about this while we're working on these 4 views during the hands-on.